I'd like to welcome you all to this evening's webinar on diabetes. I'm the CPD lead for South Wales, working for HEIW. And also I have colleagues in North Wales, David, and West Wales, Nicola. And we're going to be putting on a series of educational events. Obviously, due to COVID, most of them are going to be webinars. Some will be live webinars like tonight, some will be pre-recorded. And we're also trying some different formats. This meeting, I'm really pleased that we finally got it together. It was cancelled at very short notice, just as COVID started. So I'm really pleased to be able to get this underway. So without further ado, I'm going to pass you over to our presenter tonight. So I'm really pleased to present Sarah Davies. She's a GP in Cardiff, but also Clinical Director for Diabetes in Cardiff and Vale Health Board. She's also a Clinical Champion for Diabetes UK and an MB Medical presenter. So really pleased to be able to have her expertise on today. And I'll pass you over to Sarah. Thank you.
Thanks, Nimish. Thank you very much. Lovely introduction. Right, let's try and share the screen. Here we go, folks. Thank you so much to so many of you for joining this session tonight on a really dark, cold Wednesday evening when many of you, I'm sure, have been in the surgery. I was actually on call, and so I've just literally run in through the kitchen, poor bemused husband trying to do the kids' meals, taken off my scrubs and put on a reasonable jumper for you all. So absolute pleasure, and I'm sure many of you have been in exactly the same boat this evening. So thank you for joining. You know, I really love diabetes, especially type 2 diabetes in primary care. Anyone who's seen me talk before, you'll know that I'm super enthusiastic about it. But equally, I totally get that not everybody is. And we can easily get de-skilled. I think we have fantastic nurses, pharmacists, and so on supporting us. And things have moved on so quickly in managing type 2 diabetes over the last 5 years or so. It can be really easy to feel a little bit kind of bemused sometimes with what you're really meant to be doing. So today's all about an update in prescribing for type 2 diabetes in primary care. We're focusing on prescribing. I do another whole webinar on remission, on diet and exercise, on prevention of diabetes, and so on and so forth. But tonight is going to be very focused on the prescribing. Here are my disclosures. I have done talks for a number of pharmaceutical companies, but tonight is not pharma involved at all. Tonight's all about clinical guidelines, the current evidence, my own clinical experience. What are our learning objectives for the next 40 minutes? I'm going to kind of base it on some really new international guidance from the American and European Diabetes Associations. It was updated at the end of last year, and it's a nice kind of basis on which to think about our prescribing, particularly while we're waiting for NICE to catch up with the evidence. I very much want to talk about getting the basics right, so we're going to go through all of the medications we've got for type 2 diabetes and just go over just a few little tips and tricks and the main indications to consider. Focusing very much on the newer therapies, those SGLT2 inhibitors especially. You just can't get away from them, can you? They seem to be mentioned everywhere we go. But actually what this really means for us in primary care when you've got that patient sat in front of you. I'm going to try and evidence it all with a case study, bringing it all together, that sort of thought process that we go through. We've got a bit of time. I just want to share a little bit about COVID-19 and diabetes. It has to be mentioned, doesn't it? And we're going to finish with some really useful resources for us as healthcare practitioners and also for our patients living with diabetes. Welcome your questions as well, so pop your questions into the chat box and we'll have a little bit of time for discussion at the end before we start our Wednesday evenings. Almost forgot the day of the week then. It can feel a bit like this, can't it, looking after type 2 diabetes sometimes. You know, what are we meant to be doing? Metformin first or lifestyle interventions? This whole what next after metformin business? Should we be using the more expensive drugs or the older, cheaper ones? What about if someone's got renal impairment? What does that stop us doing? What is all this cardiovascular outcome trial buzz actually about, and what does it actually mean for us? What HbA1c targets are we really aiming for? And that's just the tip of the iceberg, isn't it, in terms of what we need to be thinking about when we're thinking about managing type 2 diabetes. And with the prescribing, it used to be so simple. We had metformin, we had gliclazide, and we had insulin. But now it just has a little feeling of being in a pick and mix shop a little bit, doesn't it? Which one should we go for now? And it definitely leads to a little bit of this, doesn't it? Some head scratching. And it's always on that really busy duty doctor afternoon, isn't it? When your fantastic practice nurse comes into your room and says, oh, Sarah, I've got this lady, type 2 diabetes, her HbA1c was this and now it's this. She's already on this and this. She's tried that but didn't get on with it. Oh, and her kidney function is this. What would you like to do next? And you go, oh my God, which one is that again? What can I give in this situation? There's a whole host of things that we can take into account when we're considering what to prescribe in type 2 diabetes. How old is the person with type 2 diabetes and how long have they had type 2 diabetes for? I could do another whole webinar about managing type 2 diabetes in older, frailer people. Because of course the evidence is very much there. Early in the course of type 2 diabetes, tight glycemic control is really important. But actually, once you've had type 2 diabetes for a very long time, particularly if you're frailer and older, actually aiming for a tight target can even be harmful. We can take our foot off the gas a bit and allow HbA1c targets to drift up, use medications that avoid hypoglycemia. It's really going to change what we're going to consider. Body weight's really important to consider, isn't it? So most of our patients living with type 2 diabetes are also living with overweight or obesity. So absolutely want to take that into account when we're considering medication choices. And of course, some of those newer agents now associated with weight loss. We want to think about comorbidities. What about renal impairment especially? What's the EGFR? What does that mean in terms of our restrictions on what we can and cannot use? Has the person already got complications? Have they got retinopathy? Have they got neuropathy? What do they do for a job? Do they work at the top of a crane? Do they drive a taxi or an HGV vehicle? We've got to think about cost, haven't we? This is the NHS. We're always told, aren't we, about the cost of these expensive drugs. This GLP-1 prescribed in Wales at one stage when they first came out. I think we have to be aware of prudent prescribing, don't we? We know actually the biggest cost in diabetes is complications. It is the end-stage kidney disease, it's the amputation. And actually good diabetes control early on in the course of the disease helps to try to prevent some of those expensive, longer-term complications. When you think about safety and tolerability, side effects, our own clinical experience with medications is important as well. And the efficacy is really important. And when I'm thinking about a medication choice, that's often where I'll start. What HbA1c am I aiming for? Because when you get that idea, it gives you a really good sort of inkling of which direction you want to go in. Think about different sex, racial, ethnic, and genetic differences between our patients. And of course, patient preference. We're all aware that the only point in prescribing a medication is if a person is going to take it. And without any question, there's no point us giving a medication that a patient doesn't want because, quite rightly, they're not going to take it. To help us in terms of our prescribing choices, well, of course, guidelines can be really helpful, can't they? They can hinder sometimes, but they can be really helpful. A nice type 2 diabetes guide dates back to 2015 now, so it's really quite out of date. It doesn't take into account any of the new outcome data that we've got for the newer agents. It's never really very easy on the eye to start off with, was it? I mean, that's a lot of words on one page. It's under review. Hopefully they're going to do a new version. It was meant to be the end of this year. I suspect that's been COVID scuppered and will probably be at some point in 2021. There's some guidance from Sign from Scotland at the end of 2017. This is a nice guidance because it's very visual. For each group of agents, it gives us a very quick reminder about what you can expect. So it reminds us about the efficacy, so what sort of drop in HbA1c you can expect, the cardiovascular benefit, the effect on weight, and so on and so forth. Quite a nice one for the consulting room wall if you struggle to remember main fors and against of each class of medication. And it started to take into account some of the newer evidence for the newer classes. But our focus this evening is going to be on this. This is the American Diabetes Association and the European Association for the Study of Diabetes consensus statement. Came out in October 2018, first of all, and it was updated at the end of last year. It's very much one of these living documents. They update it frequently as the evidence changes. Easy on the eye, nice and colourful. And it's great because it takes us down a different route depending on the main features of the person living with type 2 diabetes, allowing real individualised prescribing choices. And we're going to look at it in a bit more detail as we go through this evening. You might have your own local guidance as well. This is our type 2 diabetes prescribing pathway from Cardiff and Vale. very much based on the ADA EASD consensus statement. And you might well have your own local depending which health board you're in. The ADA EASD is worth a look, and if anyone wants me to send them the link to it, if they can't find it, then do let me know. But just Google ADA EASD 2019 and it brings it up. And it's not just about prescribing. They talk a lot about our approach towards patients, very much around this decision cycle about patient-centered care in type 2 diabetes. How that can be really important and make a big difference to engagement. It reminds us to assess those key patient characteristics that we've already considered, make a shared decision-making plan, an agreed management plan, one of these SMART plans. So it has to be specific, measurable, achievable, realistic, and time limited. So we've got someone with an HbA1c of 130, and we say, right, we've got to try and get your HbA1c to 3 in 3 months. We all know that that's going to be almost impossible to achieve. It's got to be realistic and achievable. And it reminds us that actually we need to review that management plan, have a look at why it's not working, and perhaps revise it on a regular basis. So this is the kind of top line from the ADA EASD in terms of their advice on prescribing. So you can see in the top green box there, we've still got metformin first line, along with, of course, comprehensive lifestyle intervention. After that, it takes us down a different track, depending on the main sort of overriding feature with the person that's sat in front of us that's living with type 2 diabetes. So that left-hand side, for people who have high risk or have established atherosclerotic cardiovascular disease, ASCVD, I love the abbreviations. So they've got atherosclerotic cardiovascular disease, so they've had a stroke, they've got angina, they've had an MI, anything like that, or they're high risk for cardiovascular disease. We're on that left-hand column. We also go down there if they've got heart failure or chronic kidney disease. Then it is down the right-hand side, the rest of our patients, and we go down a different column depending whether there's a particular need to minimize hypoglycemia, a compelling need to minimize weight gain or indeed promote weight loss. On the right-hand side there, where cost is the major issue. And then it guides us on our second line choice after metformin, depending on the person's main characteristics. And I'm going to have a look at a little bit more detail on what it advises us after I've gone through the main fors and against each group of agents to remind us. It's totally fascinating, I think, when you look at the change in prescribing in type 2 diabetes over the years. So this is from the UK PRD, so UK primary care data. And this is second line prescriptions. So normally someone will start on metformin, and this is their second line prescription, dating back to 2010 up until just a couple of years ago. So you can see that back in 2010, the green line, the sulfonylureas, were by far the most common second line prescription after metformin. Gradual decline in their use over the last 5 years or so, and then overtaken by the gliptins, the DPP-4 inhibitors, very popular second line choice. We're going to cover them in a bit of detail in a moment. Then you can see that pink line, that's the SGLT2 inhibitors, gradually on the rise since they came out, gosh, 7 years or so ago now. Probably have continued to be on the rise, but still remain behind the gliptins, the DPP-4 inhibitors, in terms of how often they're used second line in our patients in the UK with type 2 diabetes. Okay, so what I'm going to do now, we're going to go through each class of agent, very kind of top line, but hopefully some really helpful tips, some useful things to take back to your own practice for each class. Let's start with a very old friend, shall we? I know you already know all about metformin, everyone knows how to use metformin, it's been around for a very long time. Just a couple of hopefully useful tips for you to take back. So remains the first line medication in pretty much all national and international guidelines. We still don't really know how it works. We've had it sort of 60, 70 years, but we still don't really know how it works. It definitely does tackle insulin resistance, which is one of the key abnormalities in type 2 diabetes. Very potent. You can get a decent drop in HbA1c when you start metformin. Main problem though, we'll all know this, horrible GI side effects. So nausea, diarrhea, bloating, very common. A third, I think anecdotally, maybe even more patients on metformin will complain of GI side effects. So a couple of tips. Well, you've got everything to play for with metformin. It's really useful to get a patient established on metformin. There's such a bind when someone's not been able to tolerate it. You've got less choice. So go really slow with the titration, particularly if somebody's struggling with those GI side effects. Go back and go more slowly on that titration. It can definitely help with people adapting and the side effects settling. Of course, we know that the modified release titration can be more beneficial and can certainly be tolerated better by some patients. One really useful tip that somebody told me is that if someone's got a very high starting HbA1c, they're more likely to suffer with nasty GI side effects, probably because there's already a degree of autonomic neuropathy that's been developed. So if someone's got a very high starting HbA1c, particularly if they've got osmotic symptoms, sometimes I'll use gliclazide first of all, bring down that HbA1c, cure the osmotic symptoms, and then perhaps 6 or 8 weeks later, I'll switch them onto metformin, more likely to be able to tolerate it at that stage. The only other tip I'm going to mention about metformin is, of course, we always get concerned. People say, oh, metformin can cause lactic acidosis. Actually, that was an initial concern with metformin many years ago. And now it's become very obvious that that's actually very rare. And actually, there's only a concern about acidosis when we use metformin inappropriately in chronic kidney disease or in acute kidney injury. So I've got a number of quality improvement projects you might want to take back to the practice during the course of this presentation. And one of them is to have a look at your patients with chronic kidney disease to see if they're on the correct dose of metformin. So if the EGFR drops to less than 45, you need to reduce the dose to 500 milligrams twice a day, and stop it if the EGFR is less than 30. And then we need to remember to add metformin to our sick day guidance rules, because we want to make sure that the patient is not taking it during an acute kidney injury. So stopping those SAD-MAN drugs, metformin is the M in SAD-MAN, and I'll remind you of the others we go through. That's metformin, an old friend, something definitely want to try and use first line in the great majority of patients with type 2 diabetes. Next one, sulfonylureas, another old friend, isn't it? So gliclazide, probably most commonly used locally. You might have some people on glipizide or glimepiride as well. And we mentioned, great for those marked osmotic symptoms. Sulfonylureas work really quickly. You know, they've fallen, I think, massively out of favour, probably rightly so, particularly as the newer agents have come on board. As I always say, I think, you know, every medication we've got is a good tool in our toolbox, and we'll all have a suitable person and place and time for them to be used. And sulfonylureas are no different. I'm still using them in the right patient. So marked osmotic symptoms, really good to get a quick mode of action, quickly gets on top of those symptoms. Really useful in steroid-induced hyperglycemia as well. But definitely not the perfect class, are they? And one of the main reasons that we've moved away from using SUs is, of course, high risk of hypoglycemia. And actually, when you look at the studies, it actually looks as though hypoglycemia is as common in sulfonylurea use as when you start somebody on insulin for the first time. So we need to be really concerned about it. We need to make sure patients are aware of hypos. They need to have good driving advice and access to self-monitoring of blood glucose. I get really twitchy about sulfonylureas in chronic kidney disease. So we know that once the EGFR falls, that SU is going to be hanging around in the body for longer half-life, higher risk of nasty, persistent hypo, difficult to treat. So certainly below an EGFR of 45, I get very twitchy about sulfonylureas. And the same in frailty as well. Not a big fan at all of sulfonylurea use in frail older patients with type 2 diabetes, and indeed those who are also on insulin. So one of my favourite searches that I do every year in Woodlands, which is the surgery I'm a partner in Cardiff, is that I will run a search looking for patients with frailty. I use the EFI index for that, but you can do patients over the age of 75 who are on a sulfonylurea. I also do a search for those who have got an HbA1c of less than 58. And in those patients, I will have a look to see if deprescribing or switching of medications would be appropriate. Here's a nice summary of sulfonylureas, and I've got one of these for each of our classes now. So in terms of HbA1c efficacy, yeah, you get a great reduction with an SU. No evidence of cardiovascular benefit. In fact, concerns over the years about potential harm. Not well proven. Observational studies mainly. I think we have better options now, certainly in the setting of cardiovascular disease. High risk of hypoglycemia associated with weight gain can be a big negative for a lot of our patients with type 2 diabetes. The main adverse event is hypoglycemia. We can use them in chronic kidney disease, but with careful monitoring because of that increased hypo risk, and no evidence of any renal benefits. Pioglitazone. Anyone using Pio? Another tool in the toolbox, bear with me. I'm not going to say much because we don't use it very often, but I do use it in some patients. Directly tackles insulin resistance. So it's very good in your very insulin resistant patient. And it's very good at improving lipid profile. In fact, they use it to treat non-alcoholic steatohepatitis, both within and outside diabetes. So imagine your patient, youngish patient with type 2 diabetes, very insulin resistant, a lot of central obesity, typical kind of type 2 diabetes lipid profile. Perhaps they've got cholesterol deposition in the liver, so non-alcoholic fatty liver disease. IO can be quite useful in that setting. Not a perfect drug. There is no perfect drug. Contraindicated completely in heart failure or anyone who might be at risk of heart failure, and indeed in macular edema as well. And associated with an increased fracture risk. So anybody with a high fracture risk, and it's useful to do a fracture score if you're not sure, we need to be aware of using pioglitazone. Here's your summary. I'm going to spend too much time, so I don't think that many of us are using it very often. Moderate effect on HbA1c. Possible soft evidence in terms of cardiovascular benefit. So the PROACTIVE and IRIS trials showed some soft evidence for pioglitazone many years ago, particularly in recurrent MIs and strokes. Low risk of hypoglycemia, definitely weight gain, and probably more weight gain than we see with an SU actually. Main adverse events are fluid retention and fractures. We can use it in chronic kidney disease, but often those are patients who might be at higher fracture risk or higher heart failure risk, so it can be a bit iffy. No evidence of any renal benefits. Okay, ready for the next one? Gliptins. DPP-4 inhibitors. Been around a long time now. You know, sitagliptin is going off patent in a couple of years, and we've got a number of them now. Very useful medication. Really well tolerated, easy to use, aren't they? Because very well tolerated. I can't remember the last time I had to stop one because of a side effect. Particularly useful in certain groups. So very useful in chronic kidney disease. Can use them down to a low eGFR. We need to make sure they're on the right dose unless it's linagliptin. Otherwise, we need to change the dose as the eGFR falls, but very useful in that group. A great choice in those frail older patients I talked about. Well tolerated, and not much in the way of side effects to be concerned about. They've all had cardiovascular outcome trials performed because, of course, since rosiglitazone was withdrawn, all new diabetes drugs have had to have rigorous cardiovascular outcome safety trials. And they were all shown to be safe in cardiovascular disease. Didn't show any benefit, are safe. Very little mention there that we need to make is that in the cardiovascular outcome trial for saxagliptin, there was a small, significant increase in hospitalization for heart failure. If somebody's got heart failure and needs a gliptin, just use an alternative gliptin, not saxagliptin. The thing that I just mentioned is the problem with I see with gliptins quite a lot is that you only get a small to moderate fall in HbA1c when you start one. So if you need a fall of, more than 8 millimoles per mole in the HbA1c, gliptin is not going to get us there. Here's your summary. So low to moderate HbA1c efficacy, no evidence of cardiovascular benefit, low risk of hypoglycemia, weight neutral, very few in the way of adverse events. A little bit's been said about allergic reactions, a little bit about pemphigoid, vanishingly rare. We can use them in CKD, very useful in this group, but no evidence of any renal benefits. Next one, you still with me? Lots of information here, hopefully really useful though. This is a big one. SGLT2 inhibitors. So these are so hot at the moment, aren't they? They seem to be all over everywhere, a cure-all. I think we're going to put them in the water in a minute. And we've got 4 available now. Dapagliflozin, canagliflozin, empagliflozin. A new kid on the block is ertugliflozin. Reminder about how they work. So they work directly on the kidney. Very novel mode of action. Quite surprising when it first came out. When they work on the kidney, we're going to wee out the glucose. Amazing. So remember that in normal renal physiology, all of the glucose is reabsorbed from the proximal tubule. None is excreted in the in the urine. Simply, these simply stop that reabsorption in the proximal tubule. And sure enough, glucose is lost in the urine, so it reduces HbA1c. We also have that calorific loss. We also have a small osmotic diuresis. We get another benefit of a small reduction in blood pressure. So good HbA1c reduction, weight loss, and a small fall in blood pressure as well. And of course, the hot thing about them is from the cardiovascular outcome trial. So these trials, of course, were done to prove safety, and then lo and behold, it started showing actually cardiovascular benefits from this class of medication. And it really has been very exciting. I know I have, an interest in type 2 diabetes, but remember that for the last kind of 30 years, all we've had is a little bit of soft evidence for metformin, tiny bit of evidence for pioglitazone, but otherwise nothing we could actually do in terms of treating diabetes to reduce that cardiovascular risk, which we know people with type 2 diabetes most definitely have. So it was exciting. Yes, there were standing ovations in diabetes conferences. My husband's a GP and not into diabetes. Some of you may know him. And he thinks I'm incredibly sad for getting as excited as I do about these trials. It really has been practice changing. Now, remember that the cardiovascular benefits from the SGLT2 inhibitors are very much driven by a reduction in hospitalization for heart failure. So now we're getting some heart failure outcome trials as well. So far, we've had one for dapagliflozin, and very hot off the one for empagliflozin as well. And these are looking at these SGLT2 inhibitors, heart failure, both in people with type 2 diabetes and outside of type 2 diabetes. And actually, we've heard that actually dapagliflozin is going to get, within the next few weeks, a heart failure license. So we're going to see it probably on heart failure guidance outside of diabetes. Amazing. Cardiologists are going to steal them. So a really nice quality improvement activity. Simple search, because it doesn't bring up that many patients, probably because we haven't got that many COVID. So look for patients with type 2 diabetes, and remember it's heart failure with reduced ejection fraction. This is not preserved ejection fraction, so anyone with a reduced ejection fraction might well benefit from an SGLT2 inhibitor in terms of their diabetes and in terms of their heart failure. You'll be delighted to hear I'm not going to show a single graph tonight, because that's not what tonight's about. Tonight's about what we can do to improve our knowledge in looking after our patients with type 2 diabetes. This is a really simple summary of those cardiovascular outcome trials for the SGLT2 inhibitors. I am not going to go through the detail. They're all really different in terms of which sort of patients were in which trial. If anyone wants to talk about it a bit more, we absolutely can at the end of the course. But I think we should look at some practicalities. Renal. So we've seen heart failure benefits from the SGLT2 inhibitors, but also those cardiovascular outcome trials, secondary benefits in terms of kidney protection as well. So as well as heart failure primary outcome trials, we've now got 2 kidney outcome trials as well, looking specifically at kidney outcomes. One for canagliflozin, which is Credence, and just hot off the press, one for dapagliflozin, which is the DAPA-CKD trial. In Credence, they all had type 2 diabetes. In DAPA-CKD, they didn't. That's with and without diabetes, looking at kidney protection. So we know that until now, we've had to have an eGFR of at least 60 in order to start an SGLT2 inhibitor, and then you can carry on prescribing down to an eGFR of 45. We're hearing now, though, aren't we, about these renal benefits, that actually they can protect the kidneys from deterioration. So now we have got a renal license change. The canagliflozin is the first one that has had a renal license change, because Credence was the first renal outcome study to come out. So now with canagliflozin, you can start the lower dose, the 100 milligrams, an eGFR from 60 to 45. So that's lower than we've been able to start it before. And also you can start it at the eGFR from 45 to 30 if they've also got a high urinary ACR above 30. In that group, you can carry on prescribing down to end stage renal failure. So I can go through that again at the end if anyone's confused about that license. It's not totally straightforward, but we can now start Cana at lower eGFRs. More to follow, no doubt. We spoke, didn't we, about these work on the kidney. Are they going to destroy the kidney? No, actually. So now we know these are renally protective. When you first start one, you get a tiny drop in eGFR. That's because it actually corrects the hyperfiltration that we get in diabetes. After that, it protects the decline that we see in eGFR over time with type 2 diabetes. So no increased risk of acute kidney injury, first initial drop, but no need to do any routine checking of the eGFR beyond normal monitoring. Another improvement activity, I've done this recently actually in Woodlands, have a look for patients with type 2 diabetes with chronic kidney disease stage 3, or especially those ones with a very high urinary ACR. That's a great early marker of kidney disease in diabetes. Are they suitable for an SGLT2 inhibitor? Not the perfect drugs, are they? You know, they're really good. They're not perfect. And there's definitely a few things that we need to know about when we're using them. So mycotic genital infections are very common with the SGLT2 inhibitors. Always warn patients that might get thrush. Always warn the men, because men really don't like getting thrush. They want to know what is wrong with it and how they can treat it. So I'm really careful to advise men about thrush, particularly, and women, of course. We all had letters, didn't we, beginning of 2019, warning us about the risk of Fournier's gangrene with SGLT2 inhibitors. Not convinced at all about an association there, you know. Hasn't been seen in any of the clinical trials, big clinical trials of risky patients. These are post-marketing reports. Actually, MHRA reports 6 cases per 550,000 patient years. So vanishingly rare, thankfully. Not something I've routinely warned patients about. But I do warn them about this, DKA. So listed as a rare to very rare side effect across all the SGLT2 inhibitor class. Tends to happen when the patient becomes dehydrated. And that's why it's important that we add SGLT2 inhibitors to sick day guidance. So I tell patients to pause taking them if they become acutely unwell, especially if they're not eating and drinking properly. They get a pyelonephritis, gastroenteritis, COVID-19, and they should temporarily stop taking the SGLT2 and start it again when they're back eating and drinking. Important to remember that it's a weird sort of DKA you can get. So it's a euglycemic DKA in some cases. That means you're going to do a blood glucose. It's fairly normal. Still need to look for ketones. So do that with either a urinary dipstick or preferably, if you've got one, a blood ketone meter in the practice. So limb amputations, we're all aware of this, I think. So from one of the cardiovascular outcome trials, the one for canagliflozin, CANVAS, there's this increase seen in toe amputations in the treatment group. Again, not seen again in any of the other trials. And I think very much now the evidence base is moving away from this being a concern with this class of medications. There's lots of possible theories as to why it happened in that particular trial. It's, again, not something I get particularly concerned about. If someone's got active diabetic foot disease, I'd probably choose a different SGLT2 inhibitor. And of course, we always are going to remind people about good foot care whenever we're prescribing anything or whenever we're seeing our patients for reviews. A reminder about sick day guidance, so really clear advice. And just a reminder about this SAD-MAN mnemonic. I quite like this one. These are the medications that patients should temporarily stop taking if they become acutely unwell. There's SGLT2 inhibitors, ACE inhibitors, diuretics, metformin, ARBs, and non-steroidals. Don't forget, they've got to remember to start taking them again when they're back eating and drinking. That's often the problem we run into, isn't it? Lots of good resources out there, and I'm going to do resources actually at the end, the Trend UK leaflets and the how-to guide from the Primary Care Diabetes Society on how to advise patients on sick day rules. Here's our summary for SGLT2 inhibitors then. So moderate reduction in HbA1c seen. Yes, definitely cardiovascular benefit, particularly driven by heart failure reductions. Low risk of hypoglycemia, weight loss, main adverse event, genital mycotic infections. Can we use them in CKD? Only canagliflozin at the moment. The others I'm certain will follow. Renal benefit? Yes, they do. Secondary outcomes in the cardiovascular outcome trials. But now we've got primary outcome data for canagliflozin and dapagliflozin of definite renal protection. Last class. You're doing well, everyone. Stay with me. Doing brilliantly, we're almost there. So this is the last class, isn't it? The GLP-1 receptor agonists. There's a few of them out there now. What do you think of them? Are you using them much? Do you start them in the practice? Has the enhanced service impacted on that? There's another whole kettle of fish, worms. Anyway, they're very potent, aren't they? So you get a really good reduction in HbA1c with the GLP-1 receptor agonist, with the secondary benefit of weight loss, and often more weight loss than we see with the SGLT2 inhibitor class. Until now, they've all been injectable. So once a day injection or once weekly injection. Hot off the press, there's now an oral version. Just came out a few weeks ago, oral semaglutide. It's called Rybelsus, and you take it every day. Useful in chronic kidney disease. You can use all of the GLP-1 receptor agonists down to fairly low EGFRs. And of course, they too have had exciting positive results in some of the cardiovascular outcome trials. Unlike the SGLT2 inhibitor class, where the positive results were driven by a reduction in heart failure, the GLP-1s have been driven by a reduction in atherosclerotic cardiovascular disease, especially strokes. And of course, we haven't seen benefits in all. This is the summary. So only the green ones there are the ones where they showed benefits. So liraglutide, semaglutide, and dulaglutide are the three that have demonstrated cardiovascular benefits, particularly in reducing strokes. Not the perfect drug, not bad, but not the perfect drug. A lot of GI side effects. So they reduce gastric emptying. So a lot of people complain of bloating and nausea. In the liraglutide cardiovascular outcome trial, there was a worsening in cholecystitis seen. So I avoid liraglutide, Victoza. If somebody's got gallstones, just choose an alternative. In the semaglutide cardiovascular outcome trial, there was some worsening of retinopathy seen, probably because there was such a dramatic lowering in HbA1c. So if someone's got active retinopathy, I will avoid semaglutide. Here's your summary for GLP-1s. So high reduction in HbA1c, cardiovascular benefit, yes, specific agents only. Low risk of hypoglycemia, associated with weight loss. The main adverse events are definitely gastrointestinal. We can use them in chronic kidney disease. They have shown some renal benefits in the cardiovascular outcome trials as well, particularly on reducing albuminuria, but are well behind the SGLT2 inhibitors in terms of their effects on protecting the kidneys. Okay, let's move on. Time's ticking by so quickly. Look at that, it's already 22. I'll speed up a little bit. I've gone through our main classes there. What I just want to do is just focus quickly back onto the ADA EASD consensus statement in terms of how it guides us which drug to use when. So we know first-line therapy is metformin. Look at the left-hand side here then. We've got patients who have got high risk or established cardiovascular disease, chronic kidney disease, or heart failure. This is that left-hand side in a bit more detail. It's mainly atherosclerotic cardiovascular disease. So you've got your patient who's had an MI, angina, peripheral arterial disease. Because of that cardiovascular evidence of reducing atherosclerotic cardiovascular disease, after metformin, the recommendation is a GLP-1 receptor agonist, putting those quite high in our treatment pathway, the proven benefit. Or if we can't use that for whatever reason, SGLT2. It's mainly heart failure or chronic kidney disease. And the advice is an SGLT2 inhibitor, again with evidence of reducing those, or a GLP-1 with proven cardiovascular benefit. But what I really want to highlight from this guidance is that they actually recommend adding these agents independently of the HbA1c. So not thinking about just glycemic control, adding them to get those additional benefits in terms of cardiovascular or renal protection. I'm not going to spend too much time going down the other columns, but essentially, if you really want to avoid hypoglycemia, it recommends any agent that's not associated with hypoglycemia, second line to metformin, and then it has recommendations for third line, and so on and so forth. Same if we need to really promote weight loss. So remember, it's the SGLT2s and the GLP-1s associated with that secondary benefit of weight loss. So recommends those second line to metformin for glycemic control. Only actually where cost is the major challenge, does it recommend a sulfonylurea second line to metformin. Quite a big change, and it'll be fascinating to see what NICE say when they do come up with their updated guidance. Right, I want to do a quick case study before we finish, because I think it's nice just to illustrate our thinking just before we finish and take some questions. So big Harry Potter fans in our house. This is Mr. Hagrid. He is a 56-year-old chap. He's had type 2 diabetes for 3 years, so quite early in type 2 diabetes. Medical history, so he's had an MI 4 years ago now. He's got sleep apnea, he's on CPAP for that, and he's got erectile dysfunction. Quite a few cardiovascular, it's quite a high cardiovascular risk chap, this, isn't it? Medication, he's on metformin at the moment, 1 gram twice a day. He's a good egg, so he's a voluntary driver for the local charity minibus, and he does not want an injection. I am not having your injections, Dr. Davis, take them away from me. Here he comes for his review then. So his HbA1c is 67 millimoles per mole, eGFR is 55, the urinary ACR of 8. So I could do another whole webinar about chronic kidney disease, but his CKD stage is G3A, that's because of the eGFR, A2 because of his urinary ACR being elevated. His BMI is 32. It's quite generous for Hagrid, but okay, BMI is 32. So first of all, what is glycemic goal? So what are you trying to get to here in terms of glycemic control? So his HbA1c is 67. He's only had type 2 diabetes for a couple of years. He's fairly young, isn't it? I want to be quite aggressive here, actually. I want it less than 53. So we've got good evidence, the UK PDF study, that tight glycemic control early in the course of the disease, really important. I might even want to try and go lower. I want to be quite aggressive. So I want to get it down quite a long way. How should we do it? So here's our take a minute moment, isn't it? Let's go through them. They're all options. Okay, do you want to increase his metformin dose? He's on 1 gram twice a day. Use high dose metformin. I don't really recommend it. Lots more GI side effects, not much in the way of benefit. We're not going to do that. Add an SU. Well, glycoside will get us where we need to be. It'll bring down his A1C, but I'm concerned about hypos. He drives a minibus and also weight gain. Glutathione. He's had an MI. Is there any kind of underlying heart failure going on? Again, weight gain. A DP4 inhibitor, a gliptin. I'm worried, first of all, it's not going to get us where I want to be in terms of glycemic control. But also, I'm thinking about reducing cardiovascular risk here as well, aren't I? And I'm not going to get that from a DP4 inhibitor or any weight loss. SGLT2 inhibitor? Definitely an option, isn't it? So, I'm going to get a good reduction in HbA1c, some weight loss. I'm going to get cardiovascular protection, and I'm going to get kidney protection. So he's just gone into that chronic kidney disease stage 3. I know I can use canagliflozin so far at that stage. So unfortunately, if we think about the ADA EASD, his main issue is atherosclerosis, isn't it? So he's had an MI. So actually, that would take me to a GLP-1 agonist, ideally. He doesn't want injections. I mean, sometimes you can persuade, and we have now got oral semaglutide. Might be an option. I'll probably end up going for an SGLT2 inhibitor next. But ideally, I'd probably want this chap on a GLP-1 as well. Ideally, to really maximize the renal and cardiovascular benefits. I'm not going to go for insulin at this stage. Prefer for bariatric surgery? Maybe. NICE would say we should. I haven't got time, but certainly that is something that NICE would suggest, that we can consider bariatric surgery. If you've got a tier 3 service in your area, we know it's a great treatment for type 2 diabetes. In people with a BMI over 35, NICE would recommend expedited assessment for bariatric surgery. This is another tool in our toolbox. Don't forget, currently the NICE criteria for GLP-1 receptor agonists is quite tight, likely to change, I think, with the new guidance coming in. They still have got very tight stop criteria, looking for a reduction in HbA1c of at least 11 millimoles per mole and a reduction in body weight of 3% within 6 months. Probably because of the new evidence, a little bit lighter in terms of those stop criteria. I don't know, it'd be interesting to hear what your experience is. Okay, that's all I'm going to say about prescribing. I'm happy to take questions. We'll do a quick whiz through some resources before we finish. Sorry to run over my little talky bit. Diabetes and COVID-19, we're surrounded by COVID-19, so I'm not going to drown you with this. Just a few resources that might be useful. How to undertake a remote diabetes review. We've been doing lots of these. We've got loads of great information around it. This is from the Primary Care Diabetes Society. You can find it at Diabetes on the Net. Really nice how-to document, all about the sort of tips and tricks about doing diabetes reviews remotely. This is great. How to prioritize primary care diabetes services. So really thinking about focusing on our most at-risk patients, at risk because of their type 2 diabetes, and therefore at risk from COVID-19, but also at risk because if we leave their type 2 diabetes alone, lead them into trouble anyway. So this is a really nice how-to in terms of how you might structure searches when we're thinking about finding those patients at highest risk. This is a traffic light system, only just come out very recently. This is the recommendations for All Wales from the All Wales Diabetes Group about triaging patients with diabetes post-COVID-19 with this kind of red, amber, green traffic light system. The red patients, the ones we want to really see in the next 3 months, amber within the next 6 months. And patients in the green with good control of their type 2 diabetes, ones that we can leave reviews into next year when hopefully things are a little more settled. We'll talk a little bit more about that in the discussion if you wish. So some resources, some really good resources. So Diabetes UK information prescriptions are fantastic to use, particularly in our current difficulties with remote reviews. These are single sides of A4. There's lots of them. There's one for A1C, there's one for renal, one for foot. You can just print them off from the Diabetes UK website, or better still, go onto their website and very easily at the click of a button onto EMIS or Vision, you can have it integrated into your system, and it pre-populates with the patient's last 2 results. The space there to write the individualized target. I well recommend them. Certainly my practice nurses love using these. Leaflets from Trade, fantastic leaflets, particularly around SGLT2s, DKA, what to do when you're unwell, diabetes in your kidneys, lots of really good patient leaflets there. And from Wales, can't not mention this, can we? The Pocket Medic videos. These are short patient-orientated videos, lots of them out there. about what to eat in type 2 diabetes. A lot of them have been translated into languages. We've got the ones aimed at the BAME community. Do have a look at Pocket Medic videos. You can just send patients the link just to watch a short video, because everyone learns things by watching videos these days. My children's YouTube accounts is anything to go by. What are some resources for us? So Primary Care Diabetes Society, I do sit on the committee, so I have a little bit of a conflict of interest, of course. Loads of good resources on there, lots of good online learning. These are fantastic. My friend and colleague, Kevin, developed these for GP notebook education. They're shortcuts, they're available to anybody. And that one on the top right is particularly good. So it is a reminder about which medications you can use according to EGFR. And he keeps it updated. I well recommend having a look at that if you remind. And finally, in Wales, we've got access to this, the Cambridge Diabetes Education Programme. These are online modules to do a bit more diabetes CPD if you fancy it after this evening. To CDEP, so that's Cambridge Diabetes Education Programme, and you can register for free using the registration key code Wales, and that gets you access to all of these online modules available for anybody. So our healthcare assistants in type 2 diabetes, our practice nurses, or anybody else who might find it useful. So conclusions for this evening, I'm going to stop talking. You'll be delighted to hear. We've got loads of choices in terms of medications we can use for managing patients with type 2 diabetes. The ADA EASD consensus statement is a great guidance that really takes into account the recent evidence. Of course, diet, lifestyle and education will always remain fundamental. In terms of prescribing, metformin remains the first line therapy. And after that, important to establish whether the person is at high risk cardiovascular disease, heart failure or chronic kidney disease, because that might guide us towards these newer agents to get the secondary benefits. But remember, every type of medication has got a right at the right time where we can use it. Individualized prescribing is key, and I love the fact that in primary care, we're really good at that. We know that patient sat in front of us, we know their attitude, their history, their family and friends, and it really does allow us to make a true individualized decision. Of course, safe prescribing, awareness of cautions and side effects is so important, and sick day guidance is crucial wherever applicable. There's loads of good resources out there, both for us and to use with patients. So thank you for listening, everyone. Thank you for sticking with me. There's still lots of people logged on, so it must have been all right. And now we'll open up the floor to see if anyone's got any questions. I can see the chat box looks busy. So Nimish, are you there?
I am here. You just
stop sharing so we can see us both. He says, there we go.
Okay, brilliant. Yes, we have a few questions. Thank you, Sarah. That was really, really good, really interesting. And in fact, the resources were really useful. Just to let people know that this webinar is being recorded and will be on our GP CPD pages for people to view. Sarah, we've also had a call for some people to have a copy of the slides, so if that's okay, we can send those out as well. Question here from Alison Cooper. It's a clinical question. I had a patient in out of hours on steroid-induced diabetes, on glycoside 160 milligrams BD, the BM was 29.3. Afebrile, denied any symptoms of infection, didn't want to come to the base for a face-to-face review. What would you have been the best way to approach this?
That's a really difficult question, Alison. Great question. We know that steroid-induced hyperglycemia can be really difficult to manage. They were already on a whacking dose of glycoside. They sometimes use really high doses, and there's some really good guidance out there. The ABCD, the Association of British Clinical Diabetologists, has got a fantastic guidance, really simple flowchart for managing steroid-induced hyperglycemia. You know, the only thing you can do in that situation with a patient that refuses to be seen, safety net, isn't it? Safety net, safety net. You know, ideally, we would probably want to look for some ketones, and probably that person is heading for insulin if we're not going to be able to increase the glycoside dose, if there isn't room to do that. In that setting, in out of hours, the person doesn't want to come in, we've just got a safety net. So keep hydrated, drink plenty, making sure they're taking the glycoside that they're supposed to be taking. If they've got the ability to monitor at home, then lots of monitoring of blood glucose. If they've got the ability to check for ketones, that's fantastic as well. But many patients in that situation probably haven't, and all you can do is safety net.
Thank you very much. Got a question here from Haran Shulkar. One I think you've sort of answered. Are there any already taken GLP-1s? So semaglutide is already. Just
off the press, Nimish, actually. Yeah, so thanks for that question. Yeah, it's been on formulary in Cardiff for about 3 days, I think. So it's really hot off the press. So it's oral semaglutide. It's called Ribelsus, is the trade name for it. It's taken daily. It's not straightforward. So patients have to take it on an empty stomach. So first thing in the morning after fasting overnight. They have to take it with just a sip of water, only 120 ml of water, and then they can't have anything else for 30 minutes. So, you know, a little bit of a hassle factor in terms of that, and that's because of the absorption. It's really difficult to get a GLP-1 to be absorbed from the stomach, and that's why they've never made one before. But actually, the early trials are that you get as much in the way of glycemic lowering and weight loss from this oral option. So if you've got somebody that really does not want an injectable, then this might well be an option. And it's 3 milligrams, you tries to remember, 3 milligrams for a month and 7 milligrams for a month, and you can go up to 14 milligrams daily if needed for improved glycemic control. Interesting to see where it fits in the pathway and how patients find those instructions, I think.
Thank you. Same person was asking, if you're having problems using metformin, can you start with a GLP-1 ACE to start with?
Oh, interesting one. So it's kind of well away from NICE guidance, but you know, I think we've been forced to move away from NICE guidance because NICE guidance is now so out of date. So you can use GLP-1s on their own. I've probably got one patient in that situation. Remember, they are a more expensive option. They without a shadow of a doubt, GLP-1s are more expensive, and you might want to consider whether something like an SGLT2 might be a better first-line option as a result of that when we're thinking about costs. Like I said, it'd be fascinating to see where NICE puts these agents in the treatment pathway. But certainly, if someone doesn't tolerate metformin, then yeah, you can use these without metformin, of course.
Thank you. Shiladita Sinners asked, your approach to pre-diabetes, do you ever medicate?
Rarely. So there is some evidence for metformin in pre-diabetes. So the biggest trial was from America. It's the diabetes prevention trial from America, and there's good evidence base. So intensive lifestyle, you'd need to treat 7 patients with intensive lifestyle therapy to prevent one person with pre-diabetes going on to get type 2 diabetes. You need to treat 14 with metformin to prevent one episode of pre-diabetes becoming type 2 diabetes. So we've definitely got an evidence base for metformin. It is in NICE guidance that we can use it in pre-diabetes on an individual patient-to-patient basis. It is not my routine clinical practice. The only time I tend to use it is in PCOS. The people with perhaps PCOS, especially if they've got pre-diabetes as well, I think it can be very useful in that setting. I do not routinely use it. Watch this space. We're working hard to try and develop a proper Welsh diabetes prevention programme. It is now embarrassing that we don't have one in Wales when there's one in England and Scotland. So watch this space. It's being worked upon.
We have a question from Lydia Chong. Can we get a direct link for the diabetes on the net flowchart? Can't seem to find that. I'm not sure.
Of course. So that's the how-to guides from the Primary Care Diabetes Society. So if you go to diabetesonthenet.com, that's all one word, then it should come up if you just search for how-to on there. What I'll do, Nimish, I think that the link is on the slide, so perhaps if we are going to share the slides, they'll be able to access it directly from there.
Brilliant. Okay. And then we have a question from Kate Davies. What's the cost of the new oral GLP-1 compared to the others in the group?
Yeah, it's going to be the same, Kate. So we were really interested to see where they were going to price it. So they've priced it exactly the same as the injectables. Okay.
We don't have any other questions. Let me just check the chat bar. I think that's all we've got. Any final points? We've got 2 or 3 minutes. I've kept perfectly to time.
Oh, look at that. You see, everyone wants to go off and enjoy their Wednesday evenings, Nimish, I think. You know, it's I hope my enthusiasm has come across a little bit. You know, it's nice just to get that little update sometimes, isn't it? I'm just going to put the link for those how-to guides in the chat. Would that be helpful?
If you could do that, that'd be great.
I'll put that link in the box there, Nimish, so people can go straight to Diabetes on the Net there. And in the bottom right is the how-to series. Brilliant in terms of remote consulting. Loads of tips like the touch your toes test, which is like a home foot screen, which has been well validated. We're using that in Woodlands. The use of pre-diabetes review questionnaires, that's something I brought in during COVID that's been really helpful, just to focus the discussion a bit more. Probably carry on using, actually. Lots of good resources there.
I'd like to thank you, Sarah, for undertaking the webinar. This is the first one we've done, and I hope it went really well for people. I hope it's a format that people have enjoyed. I know that a few people on the side were having trouble. I think that's just an internet connection problem, but the majority of people had no issues at all. So thank you all, and I'll let you get away with 1 minute to spare.
Thanks so much. Good night, everyone. Thank you.
Thank you all for participating. Thanks for the questions.